Welcome back to the other side of Labor Day, I guess. So today, pharmacodynamics, right? Last week, pharmacokinetics. Today is the other side. We're doing pharmacodynamics. I don't have any follow-up or announcements, I don't think, from that. But before we get any questions or anything, before we dive into this next portion of the pharmacology part of the foundational lectures. Please, yes.
Is the link for student drug requests on D2L yet?
Say again, I missed the first part of that, please.
The link for submitting student drug requests to talk about.
Oh, thank you. Is the link for student? I don't have a link actually on D2L for the drug request or for class request. Please just email me. Yeah, thank you. Anything else? All right, let's dive in. Pharmacodynamics. So we said last time, pharmacokinetics, pharmacodynamics makes up PK/PD, analysis of what drugs do to us and what we do to them. PK, as we talked about, is ADME, absorption, distribution, metabolism, and elimination. PD is talking about what these drugs actually are, what receptors they hit, how they affect the receptors, and the like. And then, as I said, the maybe colloquial way of describing these, pharmacokinetics is what the body does to drugs. Pharmacodynamics is what drugs do to the body, all right? So, looking at pharmacodynamics, though, but well, taking a step back, actually, pharmacology is all about drugs and how they affect us, or whatever target system you're looking at. But there are two very distinct activities that a drug can have, right? Drugs really are designed to hit receptors for the most part. There's plenty of intracellular proteins that are drugged, et cetera, but kind of the canonical way of thinking about pharmacology, we're talking about drug interacting with its target receptor, all right? However, there are non-receptor mediated actions where the drug will hit something, as I just mentioned, like an intracellular protein, most often kinases to increase or decrease their activity, proteases in circulation to stop them from, those enzymes from chewing up proteins, et cetera, et cetera. But for our purposes, what we will be talking about is receptor-mediated action. So, high affinity binding for a drug at its target receptor is what we'll be really interrogating with this section. Dealing a lot with agonists and antagonists. As we talked about before, agonists are compounds that bind to a receptor and activate the receptor. We've thrown in high affinity here, right? So this just refers to the tightness of binding or how well that drug actually fits into the receptor, okay? And then antagonist is a compound that is able to bind to a receptor and prevent it from being activated, okay? Again, this works through high affinity, all right? So, next couple of slides. Yeah, last time we did some of the kinetic stuff at the end. This time I'm going to do it all at the beginning, so hopefully we'll lose everybody, but we're going to do a couple of slides. And this is for people who enjoy thinking about things this way, all right? Once I get through these two slides, I'm going to tell you what you need to know from them for the exam, so you can, we can keep these simple because, again, this isn't quantitative pharmacology. We're talking about drugs of addiction, and it's much more a theoretical class than it is quantitative. But again, I want to walk through this stuff because this is very important for the field of pharmacology. Some of us love this stuff, and if your brain thinks in this way, I just want to present it there for that. Okay, so let's take a step back and let's crawl before we walk here. So we're going to talk about how a drug affects the receptor. Two things that we need to identify are the affinity of the drug for the receptor, so how well does a drug bind to a receptor, how tightly it binds to it, and then efficacy, as we talked about before, is the effect that a drug has on the receptor or the system that you're studying. Starting with affinity, we can quantify how well a drug targets its receptor or binds to its receptor using basic principles of mass action and certain biophysical properties. Now, let's talk about this equation right here. And this is the most simplest terms of quantifying how well a drug binds to its receptor. In that, we have, in a system that's totally stripped down to these two components, we have a quantity of A and a quantity of R, right? So A in brackets is the concentration of agonist in the system. R in brackets is the concentration of receptor in a system, right? And it should be no surprise to anybody, you have the drug or an agonist, and you have a receptor, and they bind together. So in this system, you either have the two components alone, or you have the two together, right? The two together, so agonist bound to receptor can be represented by AR in brackets, or the concentration of drug bound to receptor in the system, right? Very simple. You got a drug, you got a receptor, and they're bound or they're not bound. However, this happens at a certain rate. This happens, certain amount over time, that's a rate. So you can have rate constants for this, or how well this happens. So in the forward direction, or in forming this drug receptor complex, we can call this K1. This is our forward rate constant, also called K on, because the drug is going on to the receptor. K1 is how we'll talk about it, but this is our binding constant, our forward rate constant. This is a system in equilibrium. So this is really important. So I'm going to say this once, and we don't ever have to bring it up again, because the truth of the matter is you don't just bind a drug to a receptor. In reality, the drug is binding and releasing and binding and releasing. That's the real equilibrium. The sum total of this system can be represented by drug bound to receptor, all right? But let's just think about it without all that nuance. Just remember, you have drug and receptor alone, or you have drug and receptor in complex, right? The rate that they form together is our on rate. It's in equilibrium, so we can also have an off rate, and that'll be K2, backward rate constant, or the rate constant of unbinding. We also call it K off. So we have K on and K off. We have a rate that it goes on, we have a rate that the drug comes off. But this system will eventually reach an equilibrium, okay? And at equilibrium, the change in the concentration of drug and receptor complex divided by the time is the rate, but at equilibrium this would be 0 because you're not moving in the system back and forth, okay? So this is the equation that represents the equilibrium of a drug binding to its receptor. Simply put, this can be rearranged very easily to have each of the rate constants on one side of the equation, right? Due to the fact that at equilibrium, these two are equal, so we can set them equal to each other. Here we have our on rate, our association rate times the concentration of the two individual components will equal the off rate, or the dissociation rate, times the concentration of the drug and receptor in complex. All right? This can be further rearranged by putting the rate constants together and then the components together. All of this can be then summed up by another constant called our equilibrium dissociation constant, which is called Ka. All right? All of what I just said, you can just remember Ka is our equilibrium dissociation constant for this system. And what I want you to remember is that a small Ka value equals high affinity. This would be tight binders, all right? So it also goes to follow large Ka values will be low affinity, okay? If all of this doesn't compute, please just remember small Ka values equal high affinity. And then therefore large Ka values would be lower affinity. All right? So that's talking about affinity for agonists. I said we're going to talk agonists and antagonists. So So also another application of the law of mass action, we can think about the entire population of receptors, right? Because we want to bring in our antagonists into this equation, because these are the two things we're really, the two types of drugs that we're going to be analyzing this semester in terms of what receptors they hit, but agonists and antagonists are what we need to really be well versed in. So as this shows, we can represent the entire population of receptors in this system using R sub T, right? Receptor total is R sub T, and that would be comprised of, we have either receptors that are free or receptors that are complex, right? You have the entire pool of receptors can either be in complex with a drug or they're still free. Those combined are R sub T, all right? That's where I'm going to stop walking through these equations, because to work to from here, massaging in this to this application of the law of mass action, goes outside the scope of this class. A quick aside, I have a tendency to say this goes outside the scope of this class, and I want to apologize because it's not that I don't, I know everybody can understand what we're talking about, but I'd rather stay focused on what we're talking about instead of just going off all over the place, because I'm really good at going off all over the place, and that just tends to cause confusion. Back to our law of mass action, what you can see here is we have total population of receptors set as a ratio or a fraction of those bound to drug over the total number, and then equal to our population of drug with the rate constant, or with our dissociation constant, all right? The only reason I bring this up is, as you can see here, this equation for affinity of agonist at its receptor is the exact same thing as antagonist, okay? This is going to be important for the next slide. But as you can see here, A for agonist, we're going to use B for antagonist. But the idea is, when talking about affinity of drugs for a receptor, you use the same mass action analysis for agonists and antagonists, okay? So, let's go to the next slide, then we're going to come back and do what's important here. Because now we're going to move on to efficacy, right? Efficacy has this same mass action equation applied to it for agonists and antagonists. The difference here is that we need to add this efficacy variable into this, because agonists have efficacy. Antagonists do not have efficacy. Therefore, the law of mass action is different for agonists and antagonists when we're talking about efficacy, but it's the same when we're talking about affinity. Okay? Both agonists and antagonists have a distinct affinity for a receptor. They can both bind to a receptor with certain tightness or certain attractive forces, or however you want to describe it. They can both bind. Only agonists have efficacy. Agonists have efficacy, antagonists do not have efficacy. Hopefully the last time you see these slides, or these equations for the rest of the semester, again, this isn't about quantification. I'm not going to give you an equation, some concentrations and stuff, and ask you to calculate on a quiz exam or anything. Again, this is just for people who enjoy thinking about things this way. Again, going back to a more theoretical approach to the class, what's really important here is that small k values have a high affinity. The law of mass action, when talking about affinity, is the same for agonists as it is for antagonists, because they both have affinity for a receptor. But the law of mass action for agonists and antagonists is different when you're analyzing efficacy, because agonists have efficacy, antagonists do not have efficacy. Right? How's it sound, everybody? Nice. Immediate thumbs up. All right, let's get away from this. Here's our dose response curve again. Again, as we talked about before, on the y-axis we have our efficacy. And as shown here is a percent maximum. The most common form of an efficacy plot is a percentage of response. So from 0 to 100. And then again on our x-axis, we've got our agonist in concentration, right? And this is our semi-log plot because we're in log scale here, we're in linear scale on the y. We've seen this before, we're plotting agonist, lowest concentrations close to the origin. It increases as we move away from the origin. We have this phase in here where we see all of our efficacy, and then we have another plateau on the highest concentration because we can only get so much response from a drug in a system. Cool? All right. Couple of terms here that we're introducing though are our Emax and our EC50, right? Emax is efficacy max, the maximal efficacy of a drug. Emax measures efficacy, so its value will be obtained from the y-axis. EC50 then is our other term. As we talked about before, this is actually just looking at our maximal efficacy, dividing it by half, finding where that point on the dose response curve is, dropping down to our concentration of drug on the x-axis, and that will give us our EC50 value. Effective concentration at 50% response is what EC50 stands for, and this is a measure of potency, all right? So Emax value is going to be whatever your Y value is, most commonly a percentage response. EC50 is a concentration of drug, which measures potency. So we get it from our x-axis, and yeah, it is a concentration of drug specifically. All right, so that's background. Now let's get into actual agonist-antagonist analysis. Said before, agonist binds receptor, causes a change in response, activating the receptor. Antagonist binds to a receptor, prevents a change in response. Okay, so all receptors have a certain amount of activity even when they're unbound from a drug or any sort of ligand that binds to them. All right, that's what's known as the constitutive activity of a receptor. The background level of activity or basal activity of a receptor. So here we're going to look at dose response curve. On the y-axis this time we have this measured response from 0 to 350 whatever units or units of whatever. But you can see here the constitutive activity of this receptor that's being measured sits at 100 response units. Okay, so that's the normal level of activity, and this is a much more lifelike situation. You don't have receptors at 0 activity. They do have some functionality, or they do have some efficacy inherent in them, but it really gets turned on, or it really activates once you throw agonists at it, okay? So several types of agonists or antagonists that'll be important for this class are shown here. A full agonist, shown by this green line, is exactly what it says. It gets a full response in this system, right? You get the most activity that you can from this receptor being studied. Partial agonist, again, is exactly what the name states. It's a partial response to that. So somewhere between full and 0 response, or full and constitutive activity, is where partial agonist will plateau, okay? Antagonist is here. It just freezes it at this constitutive activity level. And then the last one is called an inverse agonist. And again, as the name implies, so this one actually inactivates a receptor, causing a decrease in the activity in this system. As you can see, we're at 100 response units, drop down to roughly 0 with an inverse agonist, okay? So these are the 4 that we'll deal with during the term. Full, partial, inverse agonist, and then antagonist. All right, how does this look? Very good. All right, to belabor the point, or to hopefully, get a little bit more depth of knowledge into this, we'll talk distinctions between potency and efficacy. So we're gonna deal with the panel on the left first. Similar situation, dose response curve. Percent response on the Y, on the X, we've got our concentration of drug. We're looking at 4 different types of drugs, A, B, C, and D, right? They all have the same efficacy. Every one of these drugs reaches 100% response, right? However, they all have this at different concentrations. So they have a different potency at this receptor, all right? The more drug you need, the lower the potency of a drug. The less drug you need, the higher the potency of the drug, okay? So in this system, you can see the EC50 for all drugs, all 4 drugs is different, but the efficacy is the same, right? So we're increasing our potency as we're decreasing the dose we need to use to attain that efficacy. All right? Now on the right panel, similar setup here. On the Y, percent response. On the X-axis, concentration of drug. We're looking at A, B, C, D again here, but please know, these are not the same drugs. We're not talking about the same, they just use the same. I should probably change the number just to avoid that confusion, but know that A, B, C, D on the left and the right are not the same drugs. But here we're analyzing efficacy, right? What the drug does, and as you can see, between A, B, C, and D, they all have a different response. With A having the highest response, that reaches 100% response here, and D has the lowest response. So A has the highest efficacy, D has the lowest efficacy. But, in contrast to the first panel, here they have the same EC50. Even though these drugs have different responses, the amount that it takes to get to half of their maximal response is the same, all right? So all of these drugs, when dosed with the same amount, will have a different effect. So here we have same efficacy, different potency. Here we have different efficacy, same potency. All right, moving on. So a little bit more, or another example of this situation. Dose response curve in the same vein. Percent response on the Y, concentration of agonist on the X. Now we're looking at 2 different agonists, agonist A and agonist B. As you can see, agonist A gets to about 50% response. Agonist B gets to 100% response. So agonist B has higher efficacy than agonist A. However, as you can see, it takes much less of agonist A to reach its response than it does agonist B. So we have agonist A being more potent than agonist B, right? Even though it doesn't have better efficacy, it has a lesser effect, it still takes less of that drug to get to that effect. So agonist A is more potent, but less efficacious, okay? Agonist B is less potent, but has higher efficacy. A more real-world example of this situation we're talking about, looking at opioids specifically, right? 5 different types of opioids here, and as you can see, dramatic increase of potency between methadone and carfentanil. But yeah, the lesson remains. You can get to the same efficacy with all 5 of these, but it's going to take differing amounts. Much less for the carfentanil than it would for methadone. All right? And, okay. So, the last bit on that. Therapeutic index. Once again, we're looking at dose response curves. Maximal response on the Y, or excuse me, percent response on the Y, concentration of agonist on the X. Drug A and drug B. What we talked about before is let me back up. We looked at the way that drugs are dosed or administered, and we saw their plasma concentration and how it relates to a therapeutic effect and a toxic effect, all right? So you can look at those. For the most part, pharmacologist looked at actual dose response curves to analyze the difference between a therapeutic effect and a toxic effect. And that's shown here. So we have this drug. The therapeutic effect, or the desired effect, is to decrease blood pressure. The potential toxic effect is that it causes a cardiac arrhythmia, right? It causes your heart to beat improperly. Drug A, however, as we can see in the green line here, has this maximal effect here. Our EC50 is here, but we can see you need, 10 to the minus 9 molar of this drug to have a therapeutic response. But you keep dosing with that drug, or you keep adding more drug, and you get to the toxic effect. Here, the EC50, so maximal effect, and then EC50. And as you can see, the EC50 for the therapeutic response is about 10 to the minus 9. EC50 for the toxic response is 10 to the minus 7. Difference between those is 2. 2 logs means the therapeutic index is 100, okay? So there's 2 log units in between the EC50 of these 2 drugs. Moving over to drug B, doing the same analysis there, we see that it's only 1 log in between the therapeutic response and the toxic response, right? 10 to the minus 9 EC50 for therapeutic response of drug B, 10 to the minus 8 amount of drug B will cause the toxic effect. Why this is really important, and this is a lot more for drug discovery than that, get into it with the illicit drugs we'll talk about, but as you'll see here, so the EC50 is roughly 50% response in this system, okay? However, you can think about this in the amount of drug that you will need to actually have an effect on patients, as some patients will respond down here to a lesser concentration, other patients will need more. And where this really becomes a problem is, you can see if you draw a straight line between this 80 to 100% region of the therapeutic response on down, at this same concentration, you're going to hit 10 to 20% toxicity in this system, right? So therapeutic index is the difference in concentration between a therapeutic response and a toxic response, and you want that to be as broad as possible. Therapeutic index for drug B is 10, for drug A it's 100. As you can see here, there's no overlap here. So dosing with this drug should be safer as long as you stay at that lower range. Here, you're really going to run into problems just due to this overlap between your therapeutic response and the toxic response, okay? So, once again, therapeutic index is the difference in concentration between the therapeutic index is the difference in response between the therapeutic response and the toxic response, okay? All right, how are we now? All right, we are cruising through these. I was hoping for. Anyways, okay, let's talk about antagonism. Shift up a little bit. Talk about several types of antagonism, and then we're going to relate it to what we'll actually talk about in the class, in terms of tolerance and desensitization of receptors to drugs. But the idea of tolerance would be important for, all the drugs we're talking about. But, okay, antagonism. I said before, antagonists are agents that prevent receptors from activating, right? However, the idea of antagonism can really be expanded to more situations. Pharmacological antagonism is talking about how multiple drugs can interact with a specific receptor system, more specifically, the interplay between agonists and antagonists. because when you're in a lab, you can just study one of these at a time. But it's common to use both of them for different reasons, but they can help you interrogate how a receptor behaves. That's in a lab setting. In the real world, there are plenty of drugs that are agonists and antagonists, and just understanding how they interplay is important for our field. But back to this lecture, pharmacological antagonism is talking about how multiple drugs affect one specific receptor system, specifically an agonist and an antagonist, okay? So, looking at a hypothetical situation here on the left panel, got a dose response curve, response on Y, concentration of drug on X. When you have agonist only, we have this dose response curve we've talked about. Throw in an antagonist, and what you can see here is you right shift this plot, but you don't change the shape of it, all right? So as you can see, this agonist is still able to reach maximal efficacy, still has the same slope of the curve, it just takes more of the drug to have the same response when you have antagonist on board, okay? So, that tells us a couple things. That this is surmountable, because you can still get to a maximal response, you just need more agonists, but this is also competitive and reversible. So as shown over here, if we think about the situation that we're talking about, A is for agonist, B is for antagonist, we have these, and then R is for receptor. We have these agonist and antagonist molecules that are all trying to bind into the binding site on this receptor, all right? How well they bind is going to depend on their affinity, right? How attracted they are to that receptor, but it'll also depend on the concentration, right? Because even if you have an antagonist with higher affinity than your agonist, which is usually the case, antagonists are usually higher affinity, doesn't matter, the point is, you can outcompete that higher affinity antagonist with more agonists, right? In this situation, if we had 10 agonists and just 2 antagonists, there'd be a lot more driving force for those agonists to get into this space than there would be for the antagonists, okay? That's competitive. They're competing to bind on the same spot. So the more competitors you have, the better your chances are that you're going to occupy that space. Even if those antagonists bind tighter or have a higher affinity, you can outcompete that by dumping more agonists in that system, all right? This is also reversible. Many compounds only bind through electrostatics or hydrophobic interactions or van der Waals, if you're into that kind of thing. But the idea is that it's reversible. It's not a covalent attachment between agonist or antagonist and the receptor. So you can reverse the binding by having a higher driving force by increasing your affinity or increasing your concentration, all right? So, with all that said, pharmacological antagonism between an agonist and an antagonist is competitive and reversible. But it's talking about how drugs, agonists and antagonists, bind to a receptor. That's pharmacological antagonism. Okay? 2 other forms we're going to talk. Yes, please.
So this is with competitive antagonists. Is there other types of antagonists that make the efficacy not surmountable?
So other types of antagonists that make it not surmountable, absolutely. There's irreversible, there's non-competitive, there's uncompetitive. There's a whole thing. It's a whole thing with these guys. But for our purposes, we're going to keep it here because they don't really have those nuances in illicit drugs that we'll be talking about. So, yes, there are simple answer, but we're not going to get into that because it's, we're going to. I do mean it. We are gonna talk about drugs sometime in this class. This is just gonna be hypothetical pharmacology. Yes, so yes, it does exist, but we're not gonna get into it. Just remember pharmacological antagonism for our purposes is competitive and reversible for these reasons. Two other styles of antagonism we're gonna talk about now are chemical and physiological. Yeah, we are cruising. Okay, chemical antagonism. So everything I keep yammering on and on about is we have these agonists, and they can bind to these receptors, right? But there's lots of other things floating around in our circulation, in our brains, and in solution if you make up an, okay. Things that can compete with an agonist just by binding to the agonist are called chemical antagonists. Example would be plasma proteins. We talked about albumin, first day, second day, whatever day. Albumin can bind to an agonist and prevent it from binding to a receptor. That's a chemical antagonism situation. Some random chemical that can just bind to it and either inactivate the agonist or just sequester it away, that's chemical antagonism, okay? So chemical antagonism is some non-drug agent that binds to the agonist and prevents it from binding to the receptor, okay? Chemical antagonism, non-drug entity that binds to an agonist, preventing it from getting to its target receptor. Physiologic antagonism, a bit more involved. Here we have two different drugs and two different receptors, okay? But the two different receptors actually act on the same physiologic process. We're talking measuring heartbeat here. We're plotting our beats per minute on the Y, plotted as a function of the dose on the X. And as you can see here, the more of drug A you get, the more beats per minute you get. The more drug B you give, the less beats per minute you get. Put them in combination and you get some kind of sum total, okay? So as this shows, on the cardiac muscle, these two different receptors, A and B, when A is activated, it increases beats per minute of the heart. When B is bound, when receptor B is activated, it decreases the beats per minute. But when both are involved, it has a sum total less than A, but it's not inactivated, okay? Physiologic antagonism are two different drugs working in two different receptors that affect the same system. The overall effect is a decrease in the activation of one of the drugs. How does that sound, everybody? Good. Good. Okay, so pharmacological, chemical, physiological antagonism. All right? So let's go into tolerance. So this overlaps with what we just studied, where we talked about pharmacological antagonism. We saw a dose response curve like this, right? We're looking at response plotted as a function of dose. When you have one drug on board, you have this dose response. What we looked at is you add an antagonist to the system and it right shifts your curve. But here, when you are inexperienced with a drug, you have a certain response. If you use that drug routinely, you have a different response. Now you can get to the same level, it just takes more, right? So this looks like pharmacological antagonism, but this is drug tolerance, okay? Some of that can come into play, and we'll get into that nuance in a bit, but this is the actual effect of tolerance to a drug. You could still get to the level that, your maximal level, it's just gonna take more after repeated administration of a specific drug. refer to someone who hasn't had any drug before as naive. Someone who has had exposure to a drug or a system that has had exposure as experienced. Okay? Okay. So this decrease in sensitivity to a drug is tolerance, right? There's multiple types of tolerance. Innate tolerance is something that you just have, right? So as this lists, certain genetic variations in drugs that metabolize enzymes to be more efficient in metabolizing that drug is an innate tolerance. Certain genetic variation that cause your specific receptors to not be as responsive to a drug is another hypothetical situation for, well, real world actually, to a specific drug, okay? But that's innate tolerance, something you're just born with, something that your genes have brought out in your body. Different types of tolerance from here. So 3 other types of, now we're talking acquired tolerance. We have pharmacokinetic, we have pharmacodynamic, and then learned, all right? Pharmacokinetic tolerance, as hopefully it's, stands to reason. This is going to be tolerance that you develop as a result of a change in the distribution or the metabolism of a drug. It can be any of the 4 ADME parameters that change to allow desensitization to a drug, but it's most commonly the distribution. Really, it's the metabolism that shifts. I mean, that's for the most part. Pharmacokinetic tolerance really revolves around metabolism. You increase your metabolism of the drug, that gives you more tolerance. And the example listed here is alcohol, right? Repeated exposure to alcohol, excuse me, what's going on? Sorry, everybody. Will cause your body to increase the amount of enzymes that break down alcohol, and that is pharmacokinetic tolerance, right? Increase your metabolism, increase your tolerance, that's pharmacokinetic tolerance. Pharmacodynamic tolerance would be an adaptive change in the system, specifically the receptors themselves. You can have receptor downregulation of effector molecules. We're going to get into that in the last few slides. But remember, pharmacodynamic tolerance is about a change in the system itself, in how many receptors you have, how well those receptors respond, the effector proteins, so intracellular players that communicate from the cell, from the receptor down to the nucleus. Those sorts of changes are pharmacodynamic type of tolerance. Learned tolerance is skills developed through experience with drug. Drinking and driving, I feel like, is the easiest example of that. Because you can learn certain skills for how you behave, especially if the more used to the feeling of inebriation you get from alcohol, the better you can do certain things to a very limited extent. We'll get into all that when we talk about alcohol, but this is just an example of learned tolerance. Skills that you pick up that help you deal with the inebriation so that you seem more sober, if you will, okay? These are 3 different types of acquired tolerance, and they can all happen at the same time. You can get 1 or 2, it really depends on the individual, the drug, the amount used, et cetera, et cetera. So know that it's not an either or one of the pack. It can be everything, but these are just 3 different ways of describing types of tolerance, all right? So to that extent, we're going to be talking about pharmacodynamic tolerance from here on out, all right? Just said receptor downregulation, and that happens through a couple of different methods, right? Tolerance, another way of saying tolerance is a desensitization, okay? Desensitization to a specific drug. At the molecular level, this is what will be happening. 2 different pathways that can both happen with any drug. Both of these can happen, but either one will happen in any specific instance of tolerance. But the way that they work is like this. So on the left, We have our receptor sitting in the cell membrane, right? This receptor, here's our cell membrane, inside the cell, outside the cell. Bound to some drug, the red circle is some drug. So what happens is once this drug binds to the receptor, there's this internalization of the receptor. This membrane actually folds down inside to the cell and then will clip off and make this endosome, or make some intracellular membrane-bound organelle or vesicle compartment, where there's a dissociation of the drug, and that can be broken down and recycled or released in any number of ways. But what's really important here is that you see the receptor then can cycle back up to the receptor, to the membrane, and be embedded back in the membrane, okay? So that's internalization. Receptor bound by the drug, it's brought into the cell, there's a dissociation between these two components, and the receptor goes back out to the membrane. Internalization. Downregulation has the first start to that whole program. Drug bound to receptor, receptor is internalized. Here though, this actually changes the pH level and some other things happen, but forming a lysosome, and the entire thing gets chewed up. The receptor breaks down, the drug is broken down, everything just gets broken down in its basic parts, and it's recycled back into the intracellular pool of building blocks or whatever. But what's important here is you don't get the receptor to go back to the membrane, right? So, internalization, it recycles. Downregulation, it's broken down. And then what happens then is the receptor would have to be re-expressed in the nucleus, and then transcript comes out, it's translated and modified and all that, and then it gets transported up to this membrane to be receptive, okay? So these are two different phases, or two different ways of desensitization. But what's really important here is remember what's happening here. Because in both, even though the outcome is slightly different between the two, what's really important is once these receptors are absorbed into the cell, they're not at the surface to bind drugs, right? So this system is now desensitive, right? Desensitized to this drug, right? Because this is not three different receptors, this is the same receptor that's cycling through. Here, we're just coming inside and breaking it down. But all during this phase, there's no receptor at the membrane to bind drugs. So this system is now desensitized to the drug. That's what's really important, okay? The last detail that's important is internalization is a short-term process. This whole process is on the minutes to hours scale, usually. This whole process is more hours to days. You usually figure if you internalize a receptor before it's re-expressed and brought back up, it's usually at least a good day for that to happen, okay? So, that's what's also important. There's two different ways to desensitize: internalization or downregulation. Internalization is short, downregulation is longer term, okay? So to belabor that a bit more, this is what I just talked about. This top is a different representation of everything we just said. We've got our agonist, we've got our receptors, so these trapezoid shapes are sitting in our cell membrane. Agonist binds to them, they get internalized, right? Here's our internalization right here. Now if we go back here and we shuttle back out to the membrane, that's just going to be the internalization process, right? So it's desensitized here, but then if they're brought right back up to the membrane, it's resensitized. This process, again, seconds to minutes, can be hours, but let's think about it in terms of seconds to minutes. Quick, it's fast acting. If we go all the way over and form this lysosome and they break them down, this is the downregulation. And so we see here we have much less receptor on the membrane that can bind to drug. This process is minutes to hours, okay? This process also happens at the effector protein level. So if you remember this absurd figure that I showed first, second, whatever day of class, where we're talking about GPCRs, we got these Receptors in the membrane, they got these GPCRs. Once we bind and activate them, these go and activate intracellular proteins. All these proteins are effector proteins, okay? I show that just for reference that this can also happen the same at the effector protein level. You have an agonist binding to its receptor, same as the first situation, but here these receptors activate effector proteins. These effector proteins can be recycled or broken down, and it's the same thing. If they just recycled, it's quick, minutes to seconds. If they're broken down and need to be re-expressed from the nucleus, it's longer. Days, weeks is, yeah, it's a bit, it would take days. So, remember that, please. Pharmacodynamic tolerance happens when you have internalization or downregulation of a receptor, or you have recycling or downregulation of effector proteins, okay? So same overall effect at the system, but we're either at the receptor level or the effector protein level, and you can either recycle or you degrade, okay? And I think this is our last bit. So taking that into account, cross tolerance is one last aspect of tolerance that it's important for us, because everything we talked about before this, we've got an agonist and a receptor, and then the same agonist and the receptor, right? This also happens with drugs that bind to the same receptor, okay? Let's say you have repeated exposure to morphine, receptor downregulation happens, and then you're administered meperidine. People probably know it better as Demerol. It's kind of, yeah, that's not as popular as some of the other opiates, but Demerol is also used in clinical setting, and if you have repeated exposure to morphine, you're gonna desensitize against Demerol, against meperidine, because they target the same receptors. Receptors were downregulated due to repeated treatment with morphine, so they would also be desensitized to morphine, but a different opioid that hits the same receptor is gonna have that same desensitized effect due to the downregulation of protein, of the receptors. Same thing at the effector level. A drug hits one receptor, repeated administration of drug one at receptor one is going to activate a specific effector protein, but a different receptor can use that same effector protein. Now, when we treat with drug 2, this system is less sensitized, even though it has a full expression of receptor 2, the effector proteins that receptor 2 needs to communicate through are downregulated, okay? So once again, pharmacodynamic tolerance is talking about receptor levels and effector protein levels. They'll be internalized or recycled or downregulated. This can happen for same drug treatment or different drug treatment if they're acting at the same receptor or same effector proteins. I think that's us. Yeah. All right, hope to see you all Thursday, Tuesday.